Hello, Stephanie, can you hear me? Hello, Stephanie.
I can hear you.
Oh, good, good. How you doing?
Fine. How are you doing?
You're up early.
I was early since 2 hours ago, I think.
5:30 en Bolivia, ¿verdad?
Ahorita son las 7:30.
Oh, okay. Oh, 6:30, okay.
En Miami igual, ¿no ves? La misma zona horaria.
Lo mismo, 6:30, 6:37.
Ah, qué
¿Y tú
genial.
conoces Dr. Lanzino?
No, pero vi varias de sus publicaciones, pero no lo conocía.
Okay. Well, es poco complicada esta charla, entonces tú puedes moderar, pero necesito introducir a otra persona, ¿ok?
Sí, doctor, está bien, no se preocupe.
Tú puedes mirar, porque ya estamos aprendiendo todo. Estamos aprendiendo cómo manejar Zoom y cómo manejar hosting y todo esto.
Ah, sí, doctor. Sí, pero hay un moderador, ¿verdad? De el otro doctor, creo que es el doctor, el invitado.
Victor Hugo está invitado.
Sí,
Él va a venir seguramente. Es un gran día para él. Para network con un neurocirujano de Mayo Clinic. Wow, es bueno.
Sí, de la clínica Mayo, sí, muy genial. Qué bien.
Sí, yo creo que todo el mundo quiere trabajar allá.
Ajá, sí, doctor, muy bien.
Yo creo que Victor va a ir a Mayo antes de COVID, yo creo. Pero obviamente esto cambia todo.
Sí.
No sé si qué pasa ahora, pero él tiene mucho interés. Y Dr. Lanzino tiene interés en el trabajo de Victor porque está hablando de espina hoy. Y Victor tiene muy buen dibujos. Los dibujos es la fuerza de Victor, porque estos dibujos toman mucho tiempo para arreglar.
Sí, la edición y todo eso.
Sí, y con inyección de látex y para preparar especímenes en laboratorio. Es su vida, es su vida.
Sí, qué genial, una muy buena oportunidad para el doctor. Empieza a las 8, ¿verdad?
Sí, en 20 minutos.
Ya, qué genial. Pensé que era por la tarde y me salió la notificación en mi calendario.
No, porque Dr. Lanzino quiere empezar temprano. Él tiene tiempo a las 6 en la mañana en su hogar. Es 6, no es 7 como nosotros, 6.
Ajá, muy bien, muy bien. Y doctor, le pregunto, quisiera organizar tal vez alguna charla con los doctores en el hospital Johns Hopkins. ¿Son accesibles?
¿Tú tienes médicos para tener webcast? ¿Qué dice?
Le pregunto, digamos, si tuviera algún contacto.
Ok, escriba, no entiendo qué dice.
Ah, ya, ya.
A veces cuando una persona habla rápido no puede entender.
Ah, ya, ya. If you would like to have an event with some of the professors in Johns Hopkins University,
Oh,
if
yeah,
maybe
yeah, yeah.
you know them.
Yeah, yeah. Si tú puedes hacer conexiones, o tú conoces a alguien allá.
No conozco, pero he visto en sus redes sociales.
Oh, ok. Tú tienes poder de pregunta. Diga que trabaja con Neurosurgery TV. Es un representante o algo. Tú
Ah,
puedes
ya, ya.
hacer esto. Tú puedes
Sí,
hacer
doctor.
esto.
¿Has escuchado de la doctora Jennifer Molinteno?
Ok.
Una doctora se llama Jennifer Molinteno, pero ella no trabaja en Neurosurgery, no trabaja en Johns Hopkins. Ella trabaja en Yale, en la Universidad de Yale.
Ok. Yale. Ajá.
Sí,
Sí, buena universidad. Ok, yo regreso, ok. Necesito hacer
sí, sí,
cosas.
está bien. Hasta luego, está bien.
Ok. Ok, empezamos en 17 minutos.
Está bien, doctor, muy bien.
Good morning, Dr. Lanzino.
Good morning, everybody.
How are you today?
Good, good, very good.
Well, let me get off this pen here.
We're excited to be here and get going with this again.
Oh, good. Good. It's getting cold out there yet?
Oh, yeah. Yeah.
Already, huh?
Now winter is here.
Oh, okay, that's right. I'm in Miami. I forget what time of the year it is, actually.
Yeah, yeah,
Sometimes, I don't know, sometimes it's winter. Here's Nick.
Yeah,
Here's Nick. Yeah, Harshad is here. There's Nicholas. Good morning, Nicholas.
Morning, John. How are you?
Good, how are you?
Yeah, excellent. Thanks.
Good morning, John. Good morning,
Hey, Harsh.
Nicholas.
Morning, everyone.
It's Harshad Parekh.
Yeah.
He's a neurosurgeon from India, from
Mumbai.
Mumbai.
Yes. Hello, Professor Lanzino. How are you?
Good morning. Good, thanks.
Good morning. Good morning. Good to see you again and again.
Likewise.
We'll learn from you always.
We learn from each other.
Great, great. I was just talking to Atul today, and he was talking about you today.
Mm.
We are in the same institute.
I like special good morning and hi to our colleague from Cuba.
Oh, which one? Which one? I didn't realize.
Dr. Gomez.
Oh, good. Hi, Dr. Gomez. Just unmute there. He may have stepped away.
There's a message in the chat saying good morning from Havana, Cuba. So that's Dr. Gomez.
Yeah, sometimes connections are not good, so it's hard to put a video screen on.
I'll keep an eye on the chat. So
Okay.
morning, Dr. Gomez.
Good.
Where is Hugo? Victor, I mean.
Victor, yeah. Oh, you can't. He was chomping at the bit. Let me raise him up. I'm sure he'll be in shortly. You know, the guys that do these a lot, they come in like 2 minutes before. It kind of gets you nervous a little bit,
Mm-hmm.
but I'm sure Victor's poised. Hola, Victor.
Hola.
¿Vas a venir?
Yes, of course.
Oh, ok. Estamos aquí.
Okay, yeah.
Yeah, sí. Oh, Juan is a spine surgeon from Tampa. Good morning, Juan.
Good morning. How are you, John? Can you hear me?
Yes, we can hear you. This is Dr. Lanzino here.
Hey, good morning.
This is,
Good morning, Dr. Lanzino.
and Nicholas Borg, he's a fellow at Mayo.
Morning, nice to meet you.
Oh, here's Victor. Yeah, you just work it out with Victor how you want to structure it. Dr.
Hello.
Lanzino.
Yeah, so what I think Nick will introduce the session, and then I have 2 words about the classification, and then Victor will give us his anatomical talk, and then I have a few cases that we can discuss.
Sounds good. Is that okay, Victor?
Yeah, thank you, Dr. Lanzino. It's a great
Yeah.
honor for me to be with you here.
Hey,
Thank you
great,
so much.
great to have you, Victor. We're looking forward to your wonderful presentation.
Thank you so much.
Yeah, I was amazed from the first time I saw those latex injection of the arteries.
It's beautiful. Victor and I, we had talked about doing this since I saw that at the inauguration of the Ernest Niemi Center in China. That was the first time I saw them.
Okay, that's right. You were there, Victor, right? I think it was in
Yes.
China.
In China.
Yeah.
It's an honor to meet you, doctors. Good
Hello.
morning.
Great to
Doctor-
have you here, Juan.
Dr.
It's an
Valdivia.
honor.
Hello,
This is
how are you?
Victor Hugo Perez from Mexico.
Yes, I think you have been giving classes to my alma mater in Lima. I think you have
Okay.
been giving classes, yeah, online. And I think Dr. Lanzino, do you know Dr. Marco Marcela?
Yes, sure.
He was my teacher in Arizona in residency.
Oh,
He's very good. He always spoke highly of you.
thanks.
Yeah, we just had a webcast with Sarath from Sri Lanka.
I know it seems like a small thing, but it's really nice to have everybody's webcams on because it just feels like you're hanging out with some friends rather than talking at a computer screen. So I'm going to encourage everybody when we start the session to do that if they can.
Yeah.
Some people a little shy. Okay, we'll get 2 minutes. So Nick, I'll just introduce you.
Sounds
And
good,
then
John.
then you take it away, okay?
Sounds good. Thanks.
Yeah, just introduce yourself and introduce what you're trying to do with the show, as will Dr. Lanzino, I'm sure.
Sure.
Something, not many people are doing this, and I'm glad Dr. Lanzino decided to take a chance. Okay, we're ready to start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, it's Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have the pleasure of having Dr. Lanzino from Mayo Clinic. I'll let Nicholas Borg, a fellow from Mayo Clinic, run the show from here. Okay, welcome, Nick.
Hey, good morning, afternoon, and evening, everybody, from wherever in the world you're joining us. My name's Nick. I'm a fellow at Mayo Clinic, and we have a real treat today. Hoping to be a fantastic session with Dr. Lanzino, who's one of the most widely published neurosurgeons, talking to us about spine vascular anatomy, together with Dr. Victor Hugo Perez, who's a neuroanatomist who's dedicated much of his professional career to teaching colleagues through cadaveric dissection. Just a couple of things. I'd also like to give credit here to Dr. Lanzino's research fellow, Dr. Augusti, who's here as well. So if you want to say hello, who's put in much of the work here that you're going to see today.
Hello, everybody. Thanks, Nick.
And of course to John for setting up this platform to bring us all together. Finally, we want this to be a friendly forum as well as a professional forum. You know, this is a lot of the people that you see on this forum you might be bumping into at meetings in the next year or so. So please turn on your cameras, please say hello. If you have any questions to ask, put them in the chat. And then when we get a natural break, I'll put them to the panelists, or if you want to talk and you want to put your questions yourselves, then please feel free to do so. Order of the day is going to be Dr. Lanzino talking first about anatomical classifications of spinal vascular malformations, and then Dr. Hugo Perez talking about showing his anatomical dissections, and then we'll go back to do some cases at the end. And so with that, without further ado, I'll pass the mic to Dr. Lanzino.
Thank you, Nick. Welcome to this section. Here I'll try to share my screen. And today we chose a topic that it's something neurosurgeons we come across occasionally, and it's spinal vascular lesions. But these lesions, although heterogeneous, they represent a potential cause of reversible myelopathy. So that's why they are important, because treatment can be quite gratifying for the patient, the physician. And also often they come to our attention late, because especially the most common types, the dural spinal vascular malformations of the epidural, can be quite challenging to diagnose. When I was a resident, we had this classic classifications of spinal vascular malformations, and to be honest, they make too much sense. And besides the type 1, it was very difficult to memorize. It was very difficult to consistently remember and also apply. And then Spetzler and others brought our attention to the fact that a much more logical classifications would be based on the location of the spinal vascular shunt in relation to the spinal canal and its contents. So today we recognize paraspinal shunt, arteriovenous shunts that are around the spine and might cause symptoms of spinal cord or peripheral nerve compression, usually indirectly. And then we have, as we proceed from the external portion of the spinal canal to the inner portion, we have epidural shunts that I don't know if they're becoming more frequent, or if we are getting better with our diagnostic tools. And now it looks like definitely they are becoming one of the most common of arteriovenous shunts of the spine that we see. Then we have the what was in the traditional classification was called as and known as a type 1. This is the spinal dural vascular malformation, where the actual shunt is at or around the dural sleeve. As we can proceed from the dura to the intradural portion, then we have a variety of shunts, either direct shunts or perimedullary shunts that are located on the surface of the spinal cord. And then we have the arteriovenous malformations that share many of the characteristics of intraparenchymal arteriovenous malformations of the brain parenchyma. And after this brief introduction, just to put the arteriovenous shunts in perspective, I'll leave the stage to my colleague and friend, Dr. Victor Perez, a great neurosurgeon that has this also this passion for neuroanatomy, and he will take us through some of the neuroanatomy with particular attention to the vascular anatomy of the spinal cord.
Thank you, Dr. Lanzino. Let me. Okay. Can you see it? The whole.
Yes, we can see your screen. Yes.
Okay. Thank you so much. Thank you, Dr. Lanzino. For me, this is a great honor to be with all of you. And of course, a very nice opportunity to show this work about the injection of arteries and veins in the spinal cord. So here in this picture, we have the lumbosacral segment.
I'm sorry to interrupt. I'm not sure you're sharing the correct screen. We can see your PowerPoint, but we can't see the slideshow.
Okay. Now?
Perfect.
Oh,
perfect.
Yeah. Okay, thank you.
Thanks.
Here we have a lumbosacral segment of the spinal cord, the posterior aspect. In here we have two arteries at each side of this posterior aspect of spinal cord. They are named, or they are known as posterior spinal arteries. And here we have also a great posterior spinal cord vein. It was in Poland, Dr. Albert Adamkiewicz, who studied the spinal cord in 1850 to 1882 and 1882. A drawing obtained from an original article by Adamkiewicz showing arterial vasculature of the spinal cord and the bidirectional flow of blood in the spinal cord. Here in these excellent drawings, we have the thoracic segment and the Adamkiewicz artery. So now we have, of course, with the advancement of technology and some substance to inject into the arteries and veins, we can get these beautiful pictures. In this, we have the filum terminali, some nerves, and this is the anterior aspect of the spinal cord and posterior aspect, and these rachidial nerves. So Adamkiewicz injected arteries and veins of the spinal cord, applying some substance like carmine sediment for the red color and Prussian blue for the veins. And here we have the vertebral arteries, and this anterior spinal artery. So now with these techniques, we can get these spectacular and beautiful pictures. So here we have the basilar artery, the vertebral artery in the left side, in the right side, and hypoplastic vertebral artery. And then they're rising from this anterior spinal artery. Spinal cords were extracted via longitudinal midline posterior incision from the occiput to the sacrum. Anatomic dissection was performed until reaching the vertebral lamina. Laminectomies were performed from C1 to L5 in order to resect the complete spinal cord into the dura mater, as you can see in this picture. The spinal nerves were cut with care so not to lesion the dura mater. Red natural latex was injected into the Adamkiewicz artery under moderate pressure and close visual inspection to avoid contrast extravasation. The injection was continued until latex filled distal small caliber arterial vessels, including the posterior spinal arteries. Here you can see this injection is very nice because you can get some very small arteries, almost, or maybe arteries less than 100 micras. Great anterior radiculomedullary artery is located in the anterior aspect of the spinal cord, where it took a characteristic hairpin, and the preoperative localization of this artery is very important in the surgical transthoracic spine procedures. Here we have the characteristic way of this great anterior spinal artery, the characteristic hairpin in this picture. The artery of Adamkiewicz is located in the left side in 45 specimens, and in a right-sided was present in 5 specimens. Like in this picture, we can see the right-sided localization of this interesting artery. Here we have also another Adamkiewicz artery coming from left side, and here we have the lumbosacral segment and the end of this artery. This artery at the conus medullaris is giving rise to 3 arteries. One is coming for the filum terminal, and the other 2 are going to the posterior aspect of the spinal cord. As you can see here, 3 arteries, one for the filum terminale and the other 2 from to each side of this spinal cord. Although variability exists to the overall caliber of radiculomedullary arteries, dominant radiculomedullary arteries are present. The most important radiculomedullary artery is the arteria radicularis magna, known as the Adamkiewicz artery, and it arises in the thoracolumbar region between T8 and L2 in 75% of spinal cords, and the diameter less than 1 millimeter. So in this end of Adamkiewicz artery. So if I displace this spinal nerves from left to right side, we can see very small artery that is posterior spinal artery, but very, very small. And then here we have this end of, excuse me, let me show this. Okay, okay. This artery that you can see here is the great posterior radiculomedullary artery. This is the opposite artery into the Adamkiewicz artery. This is not a great posterior spinal artery. Here we have another 2 pictures, beautiful pictures, to show the lateral aspect of this spinal cord, the conus medullaris, and some anatomical variation in these arteries. This is the characteristic form of the thoracic and the Adamkiewicz artery. This small thoracic artery is also known as von Haller artery. The preoperative localization of this artery is very important in the surgical transthoracic spinal cord. Here we have the Adamkiewicz artery arising from T3, the highest level in this 50 spinal cord study. Here we have the 1, 2, 3, 4, 5, 6, 7, 8 cervical spinal nerves, and then 1, 2, 3. In this was the highest level in the origin of this Adamkiewicz artery. And here we have the thoracic segment. In this case, we do not see a contributor to this anterior spinal artery because of the great size of this anterior spinal artery. This is a close view, and this was the lowest level in the arising from left to. As you can see, if we displace these spinal nerves, we can see the lateral aspect of this lumbosacral segment, the conus medullaris, and this is the anterior and posterior aspect and lateral aspect. This Adamkiewicz artery ends at the conus medullaris and is giving rise in this case to this important artery known as posterior medullary artery. This is a table with the localization of this Adamkiewicz artery. It is coming from T9 in most of the cases, in 13 and T8, 10. This is in this specimen we had, excuse me, sorry, okay, another pictures showing this let me show you dissection of the posterior aspect of this spinal cord.
En este video vemos la cara posterior.
Here we can see the posterior aspect and conus medullaris, filum terminali, and then continue dissection. Conus medullaris is in here. Then filum terminali. And the thin arteries of these spinal nerves. Anatomy of the great posterior radiculomedullary artery. Understanding of the basic vascular anatomy of this artery is utmost importance for imaging interpretation and endovascular and surgical management of spinal cord vascular malformations. Here we have great posterior spinal artery and other one. The anatomy of this artery was denied by some researchers, and others do not mention this artery. According to Jellinger, a large posterior radicular artery is seen caudally in about 75% of instances. So there is no doubt about the existence of this interesting artery, the great posterior radiculomedullary artery. In this case, here we have an injection of this great posterior spinal artery. Look the posterior aspect of this spinal cord and the injection. The injection was, first of all, we located this artery, and then with a very small syringe, we inject some liquid to get this interesting video about this artery. And here we have a dissection of
This is a great posterior radiculomedullary artery. It is coming along to the 12th thoracic nerve root in the right side. This artery makes a curve and goes to the posterolateral aspect of this spinal cord. Then returns to the posterior aspect between L3 and L4 nerves. This is here we have the posterior spinal artery that is coming from the Adamkiewicz artery. This is the posterolateral aspect of this spinal cord. Here we have the posterior spinal artery. This artery is going to make a beautiful anastomosis with the great posterior radiculomedullary artery.
So then we have the great posterior radiculomedullary artery joining with this posterior spinal artery. In the next video, let me show you this.
Let me show you in this video a very significant fissure. So in this side of this spinal cord, the left side, we don't have an anastomosis between the posterior spinal cord with the Adamkiewicz artery at the conus medullaris.
This artery was injected in 50 specimens, and in this spinal cord, there was not GPRA. Instead, there were several radicular arteries, as you can see in these beautiful pictures. So when you don't find a great posterior radiculomedullary artery, the blood, the irrigation of the spinal cord is coming from several and very thin arteries that are running along with these spinal nerves. A GPRA was identified in 72% of spinal cord specimens. These total include specimens in which unilateral and bilateral GPRA were found, as well as a single case in which 3 were evident. In 22% of specimens, bilateral GPRA were present, 11 from 50 spinal cords. This is one specimen with 3 right-sided GPRA. The distribution of this artery is it is coming in 9 in T12, left side and also in the right side. So there is no doubt about the existence of this artery. The thoracic artery arises from right side in this case and in the left side. This artery this is known as a contributor to the anterior spinal artery. This is also known as von Haller artery. At least one artery of von Haller distinct from the Adamkiewicz artery was identified between T1 and T8 in 47 of the 50 spinal cords. An artery of von Haller was not identified in 3 spinal cords. A single artery of von Haller was identified in 47 patients, with 39 arising on the left side and 8 arising on the right side. This is a very important artery because it's contributing to the irrigation of the small thoracic segment of the spinal cord. The narrowing of the thoracic segment of the anterior spinal artery has an average diameter of 0.33 millimeters, 170 micras to 500 micras. The measure was done in these spinal cords at the thoracic 5 level. As you can see in here, this thin anterior spinal artery. So a single artery of the bone Haller was identified in 47 spinal cords with 39 arising on the left side. So respect to the veins, look at these beautiful videos. In here we have a big posterior spinal vein, in this case, in the superior video. As you can see in this superior video, we have a single great posterior spinal vein, like in this case. And in the other one, let me show you the inferior video. Looking here how several veins contribute to the venous drainage of this lumbosacral segment of this spinal cord. This is very interesting because in some spinal cords, we have several drainage veins. And in the other, like in the superior, we have a single vein. So let's go to the next slide. This is a great spinal anterior vein. The measure of this was about 0.8 millimeters. This is another big spinal vein. Some scores in this posterior spinal base. I am trying to make a classification of these veins. Posterior spinal vein, this measures 1.48 millimeters. This is really beautiful, this spinal vein in the posterior aspect of spinal cord. And sometimes we can see this anatomical variation in the spinal veins. And here we have a dissection of the arachnoid in the posterior aspect of the spinal cord. It's easy to dissect this arachnoid in the posterior aspect. In the anterior aspect, I think it's much better to dissect this arachnoid because it is not attached firmly over the spinal cord. So here we have a close inspection of this anatomical variation of this vein. Conclusions about this artery is about the great posterior radicular artery is present in most individuals, 72%. Here we have a lateral aspect of this spinal cord. And now I am trying to make a classification of the veins. Adamkiewicz said in that time that it's not easy to classificate the veins in the spinal cord because of the great variability that they have. In these 50 spinal cords, we found a dural fistula that I'd like to show you in other time. Thank you, Dr. Lanzino. This is very nice for me, and this is a great opportunity to show this work. I have been working in injection of brain for almost 33 years in the Forensic Institute in Mexico City, and I began to work with spinal cord almost 50 years ago. I talked with Dr. Roton in a Congress in Central America, and I asked him if he was doing research about vasculature of the spine. So he told me that not just study arteries and veins in brain. And I thought that it was a great opportunity for me to study much better this vasculature. Thank you so much for all of you.
Thanks, Dr. Paris. That was fantastic, and you've got some beautiful illustrations. We've got a couple of questions for you, if you're able to take them before we move on. The first question comes from one of my colleagues in the UK. You mentioned 72% of your specimens you found the artery. Are you able to say in the ones where you didn't find the artery, were some of the other arteries more prominent to compensate, or did you not notice such a pattern? I think you might be muted.
Yeah. The arteries that compensate the irrigation of the posterior spinal cord are the very thin arteries that are running along to the posterior spinal nerves. But only 72% of these spinal cords had a great posterior radiculomedullary artery.
And I guess the question is, in the specimens where you don't find that artery, do you find, for instance, that the anterior spinal artery is larger, or is there no such relationship?
Again, please.
In the specimens where you don't find the great posterior radiculomedullary artery, do you then notice that the anterior spinal artery of Adamkiewicz is larger?
Yeah, this is a nice question. If in the specimens we didn't find a great posterior radicular artery, there is a very nice bifurcation at the end of the Adamkiewicz artery. So this is giving rise two arteries in the posterior spinal cord. And I think that is the compensation in those spinal cords.
Victor, is it possible if you can share your screen again? And if you go back, you showed us an incredible presentation, all slides beautiful. There was one slide where you show us at the bottom of the spinal cord, the anterior spinal artery gives 3 branches at the level of the conus. Okay. Can you show that slide again? Because that slide is very, very important to understand the anatomy of the perimedullary spinal fistulas and why those arteriovenous shunts that are typically at the level of the conus, they have this complicated anatomy where there is supply that comes from the anterior spinal artery, but as it goes around the conus and then gives rises to some posterior. So if you can show that slide again, that is great.
Okay, I think
this
is this
I
one.
don't think we're seeing your slides right now. We're just seeing
No, it was one of the early slides that you showed about the anterior spinal artery, where you show the conus that there are 3 branches.
This one.
We are seeing your screen. We are seeing your
we're seeing
screen.
slide 54 at the moment.
Yeah. Okay, let me go ahead. Now?
Yeah.
Yes, this one.
Is this slide?
Yeah, this is the slides where it shows at the bottom. If you can go through this anatomy again, because this is very important to understand the perimedullary arteriovenous fistula arteriovenous shunts. So if you can take us again, so basically we're looking at the bottom of the anterior spinal artery, and then it continues with the artery of the phylum that goes straight down. But then there are 2 other branches that go around the conus and go to the posterior spinal artery. So that's a beautiful demonstration of what is the so-called basket of the conus, where there are these anastomoses, the anterior spinal goes around, and anastomoses with the posterior spinal artery system. And then what we can see here is the continuation of the anterior spinal artery at the bottom, if the artery of the phylum terminale, which is another very important artery to understand a rare but a very specific type of arteriovenous shunt, which are the fistulas of the phylum terminale. Which, interestingly enough, this fistula of the phylum terminalis can often be associated with the other spinal vascular shunt. So that's a great. And can you show us again the video about the injection of the anterior spinal artery? Because that's, I cannot watch that video enough. It's so incredible, and you know, to see it and beautiful and understand how blood flows into the thoracolumbar spinal cord. So.
With this kind of injection, you can go into the very thin arteries, as we can see in this case. So again, I am injecting this Adamkiewicz artery. And this is the conus medullaris in here.
Beautiful. Victor, do you have any idea why there is such a strong predominance of the anterior spinal artery, the greater anterior spinal artery, to arise from the left side? Is it in relation to the position of the aorta, you think, or is there any other possible anatomical or physiological reason for it?
No, I think it could be for the localization of the aorta.
Yeah.
Yes, must be that. Yes.
Great, excellent. We've got a few more questions from the audience, if that's okay. Dr. Valdivia, do you want to ask your question? Do you want to go next?
Yes, Dr. Victor, this is amazing work. I personally do a lot of complex spine surgery, and routinely I do not approach the spine from the left between those segments, T8 and L2 or upper lumbar spine, because of Adamkiewicz. So I believe that the spine surgery is so prevalent in the US that procedures such as transforaminal lumbar interbody fusion or corpectomy, or even the minimally invasive transpedicular approach for herniated disc, for example, may place this artery at risk. This is a question for the audience and for the panelists. What test would you recommend to get preoperatively to determine the best location for adamantiosis? CT aortogram of the chest and abdomen, or a standard digital subtraction angiogram? What would you think?
I think first of all, not in all the countries we have the opportunity to do this kind of studies. But I think the conventional digital subtraction arteriogram is enough because the Adamkiewicz artery is big, almost 1 millimeter. So you can see it here in all the studies. So in right now, I have advanced the study in 60 spinal cords, and I have found 2 Adamkiewicz artery coming from T3 in the left side, not only one that I showed you, 2 arteries coming from a very high level, T3. So I think this is very important because if the vascular surgeon is going to make a clamp into the aorta to treat an aneurysm of an aortic aneurysm, so you are not going to have in these 2 cases an ischemic injury to the spinal cord because of the high level of the localization. But what I have seen is that spinal cord has a very nice contribution of blood in the anterior and in the posterior part of the spinal cord.
Thank you.
Thank you, Dr. Valdivia.
We've got one more question from Dr. Perec. Dr. Perec, you got access to a microphone? Do you want to ask it yourself?
Hi, Victor.
Hello, Dr. Perec. Nice to see you.
Nice to see you. Excellent lecture as always. I see wonderful demonstrations. Please pardon my ignorance on this question about the veins. Are these veins has got a similar kind of anatomy what we see in a brain? Are they having walls? We cannot sacrifice veins in brain. If we sacrifice the veins in a spinal cord, does it cause the similar kind of infarcts what we see in the brain? I'm sorry to ask you this question because I'm ignorant about it.
Well, I think that we should not sacrifice veins in a common procedure for example, for disc herniation or something like that. Because if we have a small hemorrhage in these veins, we should try to use a compression and not to sacrifice, because you have the reason. If we sacrifice an important vein, we could have an ischemic lesion into the spinal cord. Because of congestion. As I showed you 2 videos. One in only a single spinal vein is drainage the blood. And in the other one, there were several affluents, several veins that drains the blood. So I think it's very important to respect these veins. And I am doing also now a study of the cervical arteries. I think they are very important because if we know the localization of these cervical spinal arteries, you know that it is very common to make a surgical intervention for a disc in the cervical segment. I think it's very important to know where is located the cervical spine arteries. Dr. Lanzino, I want to show you this the advance in these cervical arteries in order to publish that features. Thank you.
Victor,
Thank you, Victor. Thank you.
Can you comment, like when you read the textbooks and when you do surgery for intramedullary tumor, for example, it's not easy where the tumor is localized to identify the posterior median sulcus because the spinal cord is expanded. Some of these tumors are a little bit eccentric. And so one of the textbook explanations on how to recognize in this situation the posterior median sulcus is that they say there is always a vein that runs over the posterior median sulcus, but that's also what I have observed during surgery. It's not completely true because the main dorsal vein, might not be necessarily right smack in the middle, and it's always very, very tortuous. Can you comment about that? That yes, it gives you some ideas where the posterior median sulcus might be, but the vein is really never right in the middle.
Yes, I agree with you, Dr. Lanzino. Specifically in the posterior aspect of the spinal cord, we do not localize a middle vein, the location of the middle vein. So I think you cannot guide in this way. I have not seen that. I agree with you. Veins in the posterior aspect of the spinal cord are located in right, left. Maybe you can find some of them in the middle, but this is not a statement. You know.
Thanks. I'll go and share my screen and after this beautiful presentation, we'll just present a case, and this case will allow us to discuss about the most common type of arteriovenous shunt of the spinal cord, which is the so-called type 1 or spinal dural fistula. So the clinical presentation here is very, very typical. 82-year-old man with the progressive weakness, which starts in on one side, bilateral loss of sensation below the knee, and some degree of urinary retention. So here you have very important factors. Number one is that these dural fistulas are much more common in men than women, and they tend to affect patients in their often in their 8th, 9th decade of life. So these are elderly patients, and that's also very important for diagnostic purposes because number one, you do an MRI of the thoracolumbar spine in these patients, and they often have, everybody at that age has some degree of degenerative disease, and we see not infrequently the patients might have operations, spinal operations for degenerative disease for symptoms that then in retrospect were related to the fistula. Now here, in this case, it's a bit atypical in the sense that you see T2 changes within the spinal cord. And you can see that when we have a fistula, a dural AV shunt of the spine, the symptoms are related to an ascending myelopathy. So the area that are more likely to suffer are the areas that are at the bottom of the spinal cord, irrespective of the location of the fistula. So when there are T2 changes on the MRI, these T2 changes, like in this case, almost invariably, almost always extend down to the conus. Now, we also say that it's a classic to see flow voids, but of course, we tend to see a lot of those fistulas that are difficult to find. So you can see, like in this case, the presence, the classic presence of flow voids on T2, it's not always such a classic or immediately visible finding. Now, despite advances in non-invasive imaging, we still feel that catheter spinal angiography is the gold standard for these lesions. We always do a MRA of the spine before doing the spinal angiogram. The reason why we do the MRA is that to try to identify or narrow down the potential levels where the fistula might be related, so that when we do the angiogram, instead of starting from brain vessels and going down, we start concentrating first on those segments where we are more likely to find the fistula. And only after we found the fistula, then we can complete the angiogram to look at other segments, which is important to localize to recognize the origin of the Adamkiewicz. And it's also important to rule out the exceptional possible associations of a spinal dural fistula with the other vascular malformations of the spine. So in this case, you can see this is a T12 intercostal injection, and this is the classic appearance of the type 1 true dural fistula, where you can see that there is a small nidus, and then there is the arterialized vein that usually, although not always, it's localized underneath the ipsilateral corresponding pedicle, and often surgically you find it immediately behind and above the corresponding nerve root. So this is the classical finding. This is very important to recognize this area of transition from a tiny little arterial nidus to the draining vein, because this allows you to differentiate the dural fistula from the epidural ones, which again, I stress, are not that uncommon. In the epidural fistulas, what you see an epidural pouch. The shunt is in the epidural space, and only secondarily you can have retrograde intradural spinal drainage. So here, important to recognize, this is a classic dural fistula, because you see the transition from a tiny little arterial nidus at the level of the dura sleeve into the vein, which emerges from the dura and then runs on the dorsal aspects of the spinal cord. And here it's a particular where you see here the tiny little feeders, and then you see the transition, and then you can see here the intradural vein as it emerges from the dura. And in this patient, this was a right T12 injection where the fistula is localized, but you can see that when we inject the contralateral side, you have you see injection of both intercostal, but from the other side there is the origin. You can see a depiction of the from the left side of the spinal artery at the same level but opposite side. Now, the formal catheter angiography, it's not always very easy in these patients, primarily because, as I said, they tend to be in the 7th, 8th decade of life. There is often atherosclerosis, and to be able to identify, to catheterize every single level really often requires a certain level of experience. And then there are some of the high thoracic levels, and Victor talked about the spinal artery in 3 of his specimens arising from T3. Those are very high levels that are not easy to catheterize. Now, there is a lot of discussion for a spinal dural fistula surgery versus endovascular. We know that there is no question that even in the modern era, endovascular treatment is less effective than surgery in completely curing the fistula, because in order to cure the fistula, you need to occlude, you need to close the proximal segment of the arterialized intradural vein. And as we saw, those vessels that are feeding the fistulas are very small and tortuous. It's difficult to achieve a position distal enough to allow for an effective embolization. So the other thing is that these patients often they have symptoms and progressive symptoms, and we like as much as possible to offer a definitive treatment. So we know the fistula is treated, and if the symptoms don't improve, it's not because the fistula is still present, but because of damage that had been done before the treatment. So we tend to prefer surgery, but of course we do offer embolization, but we are very strict in when we consider embolization rather than surgery. And then it's always important, especially with the liquid embolic agents, we have to be careful because the feeder might share supply to the spinal cord, and Victor has shown us that the anatomy of the spinal cord vascularity, there are a lot of variations. Another thing that I found that's very important is that these patients are often overweight, they are elderly, and the most common location of the fistula is in the thoracolumbar spine, and if the lumbar levels are involved and it's a true dural spinal fistula, it's usually the first 3 levels. So especially when the fistula is localized in the mid upper thoracic cord, I found it very important and very useful to have some sort of marker that is placed in the under fluoroscopy before the surgery, so that during surgery, the level it's very easy to identify. I think nowadays we do a lot of intraoperative spinal neuronavigation, so this might be less important, but traditionally that's what I have done. Now, I always tell patients when we suspect a fistula, I always tell them the most difficult part of the entire process is to actually find and localize the fistula. Once you find the fistula and you ascertain that it's a true dural spinal fistula, then as we know, the treatment is pretty straightforward. You expose the level, you open the dura, identify the arterialized vein as emerges from the dura, which is often, although not always, at the level of the corresponding pedicle parallel to the exit nerve root. Once you identify the proximal arterialized draining vein at the point of emergence from the dura, coagulation and division of the vein results in a cure of the fistula. So it's a pretty straightforward, it's a laminectomy and a pretty straightforward surgical procedure. Now, it's important to stress that as you are doing after you do your laminectomy, you may see, as in this case, this is a patient that had been previously embolized with onyx, with incomplete occlusion, hence the appearance of the vein. But you can often see over the dura, you can often see the convergence of the dilated and hypertrophic dural feeders. But again, the treatment is not coagulation of these feeders, but it's opening the dura, identify the proximal portion of the arterialized draining vein and closure of that part. When you when you see this, I also discourage to coagulate this before you open the dura, because if you coagulate the feeding arteries as they go into the dura or through the dura, there is a lot of controversy versus where the actual point of fistula is. But if you coagulate these arteries, then when you open the dura, the arterialized vein might not be so classic in appearance or so immediately evident, because you have devascularized most of the fistula. Now, after you do a few of these, then it becomes, once you see it, you see a few, then you immediately recognize. And here is, you open the dura, and so we are from posterior, and you can see a beautiful view of the arterialized retrograde intradural vein, and often at the point of transition from the dura to the actual vein, you can see that there are some calcifications because of the arterialization of the veins. Some think that the actual shunt might actually be at this level, actually intradural. And again, this is another on the top, and the A panel, you can see the arterialized vein as it emerges from the dura. And here, after placement of a temporary clip, you can see how the arterialized vein, you interrupt the shunt, and the arterialized vein becomes blue, and you can compare to the color, typical arterial color before placement of the temporary clip. Here it's another example. You open the dura, find the arterialized vein, and here you can see, because of the high pressure shunt, the veins over time, they become much more tortuous or convoluted than in a normal situation. And again, here you see a particular of the, after releasing some of the arachnoidal bands, you see a particular of the arterialized vein as it emerges from the dura. And here you see the relationship with the exiting corresponding vein. So the basic steps of the surgery are dura opening and suspension, and we'll illustrate this in a brief video. I like to open the arachnoid separate from the dura. Nowadays, we do a very focused dura opening, and we go down, trying to minimize the arachnoidal opening. We go down right over the arterialized vein. So once you identify the area of the arterialized draining vein, there are some arachnoidal adhesions, and you isolate the proximal segment. I like to do an ICG fluorescent before and after placing a temporary clip. It's not necessary, but I like to have that further confirmation that I found the fistula, and indeed that's what I'm looking at. And then coagulation and division of the proximal arterialized veins. Now, the other thing about, we all talk about changes in the color of the draining vein after temporary clipping or after occlusion. The truth is that quite often it's not so immediate, and it might take some time, several minutes, before you can definitely see a change in the color of the draining vein after interruption of the fistula. Here is the video. So there is nowadays with the minimal invasive spine procedure, this is something that once you know the location of the fistula, again, you need to expose that area of the pedicle, so you can do it with the minimal invasive technique. Some people do it through hemilaminectomy. Some people do it through a full laminectomy. Of course, I think that's a bit of dealer choice as you want to achieve this. But you can see here, after opening of the arachnoid, as I said, we try the dura separate from the arachnoid. We try to go right down to the point of emergence of the arterialized vein. So we minimize the arachnoid opening to further protect the intraspinal contents. Here you see the arterialized vein. We separate the arterialized vein from the dura sleeve. And from the corresponding nerve, and once we have an adequate segment, I prefer coagulation to leaving a permanent clip, so there is no artifact. And once I left the surgical clip, instead of coagulating and dividing, and the patient developed tethering, that I had to go and release. And as I said, the difficult part is to find and understand. Once you find and understand the treatment, it's pretty straightforward. But I warn you about being sure that you are able to differentiate this more common type, the true dura fistula that has a typical appearance, from the other type, which is the epidural arteriovenous shunt, that has some slight different characteristics. It's higher flow, and actually the epidural ones are the ones where we have great success with embolization rather than with surgery. As I said, the surgery is fairly effective, and if you understand correctly, this is one of our older publications in neurosurgery. It's highly effective. Here it's another particular of an example I showed before. You can see the emergence of the draining vein, and here it's after coagulation and division, and you see that the veins also, they become less conspicuous and are under decreased tension. So why is this important? Yes, it's true, they are uncommon, but they represent an important cause of correctable myelopathy, and with an increased life expectancy throughout the world, they are becoming more and more common, because people live longer, and as I said, that they are typically seen in men in their 7th and 8th decade of life. And there is this question whether or not the epidural type, which we will discuss in the next sets of lectures, there is a question whether the epidural type is becoming more common, or we are getting better at diagnosing them. Now, for the younger colleagues in the audience that are the ones that will make contributions to advancement of our specialty, here is something to think about. So I kept saying that these spinal dural fistulas are much more common in men than women. They are typically involved, doesn't mean that we have definitely seen patients, very young patients in their 30s or 40s, but usually these are men in their between 60s or their 80s. And so why there is this, particular gender and age predominance? And the other thing that is fascinating to me is that unlike the epidural counterpart, which tend to be much more common in the lower lumbar segments and in the proximal sacral segments, the true spinal dural fistulas are usually in the mid to lower thoracic segments if they involve the lumbar spines. It's usually between L1 and L3. Why there is this, and they're exceptional in the cervical spine. So if you think about, there is what is the common denominator between the mid lower thoracic segments and L1, L2? It's probably these are segments of the spine that are less mobile as opposed to the cervical segments or L3, L3-4 and L4, L5 and L5S1. So something to think about. And I think that if we can understand these peculiarities, we might be able to understand also the reason why they form. Here is when we looked in 2018, so now it's 3 years older, we looked at our over 200 AV shunts that we have seen over time. You can see that the dural type is by far the most common. It's over 50% of the spinal vascular AV shunt that we see and treat. But again, I will draw your attention, and we can, as I said, we will talk in one of the next installments of this series about the epidural type, that it's not that uncommon and shares different anatomical, definitely different anatomical characteristics. And once again, I stress it again, the treatment is also different, because for the epidural AV shunt, epidural arteriovenous shunt, embolization is very effective, and surgery to actually treat the fistula can be a bit challenging because they are in the epidural space, and usually they are located ventrolateral to the dural sac. So it's not easy to necessarily to expose. Here, as I said, for the younger colleagues, something to think about, not only younger colleagues, all of us, but the younger colleagues are the ones, as I said, that are more likely to make contributions in the future. And here you see that when we look at the dural spinal vascular malformations, definitely way more common in the thoracic segment. So relatively, or I would say less mobile segments of the spine. And in the still in the common in the lumbar, but you can see as you move toward the lower portion of the spines, then the epidural type becomes much more common than in the thoracic segments. So as I said, that they are almost exceptional in the cervical spine. If you exclude, the craniocervical junction fistulas, they are very similar to the spinal vascular AV shunts that we discussed, but those are typically located at C1 or at the level of the foramen magnum. It's exceptional to find the true dural AV shunt in the remaining segments of the cervical spine. So the pathophysiology of the symptoms is related to venous congestion. As I said, it's an ascending myelopathy. And once again, I found this very helpful because we have a very active section in neurology that deals with autoimmune disease of the spinal cord. And often when they cannot clearly diagnose a patient with the specific problem and the patient has T2 changes on the MRI, we're often asked, do you think this patient might have a fistula? And again, even though this is not an absolute, usually if there are T2 changes on the MRI, since this is an ascending myelopathy, so the lower areas are the ones that start suffering first, then if there are T2 changes, they are always, the conus is almost always involved. There is not, it's not patching only in the mid-thoracic spine, for example. And remember, the T2 changes have really little relationship with the localization of the fistula. Now, another thing to think about, and Victor here might give us a potential answer, is that if you think about these patients, even if when you don't find the fistula and the fistula goes untreated for a long period of time, I don't remember ever seeing a patient where the symptom starts in the lower spine, so affects the lower extremities, bowel and bladder function. I don't remember ever seeing a patient in over 200 cases of spinal dural fistulas where the upper extremities eventually were involved. And I think that probably has to do with the ability of vascularization, of collateralization of the venous system at those levels, or might have to do with the different physiology of the veins as we consider different segments of the spinal cord. Now here I will go through some, some few curiosities that we have encountered, and some practical tips. As I said, the flow voids, of course, when you see this, the diagnosis, you can make a diagnosis just on a sagittal MRI. You see T2 changes, the extent to the conus and the flow voids. Well, that's definitely a spinal vascular AV shunt. Now, what we have learned, seeing a lot of these patients and listening to these stories, it's not uncommon at the beginning. Some of these patients are treated for myelitis, and they are admitted in the hospital and they receive high dose steroids, IV steroids. And what we have noticed that if a patient has a fistula and receives high dose intravenous steroids, quite often this is associated with a neurological deterioration. So we came to the conclusion that this is a venous problem and steroids are actually contraindicated. And we collected and looked at this problem. If anybody is interested, this is the publication in the Journal of Neurointerventional Surgery. So we saw that many of those patients that were treated with high-dose steroids, because at the beginning, the problem was misdiagnosed as transverse myelitis, they had the neurological deterioration shortly after the administration of steroids. And that we think is that because this is a venous problem, you give steroids, and with steroids, there is an increased intravascular fluid retention, which in turn in this patient that have altered venous drainage can cause a worsening of the venous hypertension, and therefore worsening of the clinical symptoms. So I thought that this was a practical pitfall that is important to consider. And I'm sure that as you start seeing some of these patients and you question and you get the history, you will find similar type of stories. I think it's 7:20. I will stop here. We have had a wonderful session. I'm sure that there will be comments and questions, which we all are happy to discuss. And we will continue. The next installment will be along the same lines. We will discuss other vascular malformations of the spinal cord, so that we cover as much as we can this topic that, as I said, these lesions are not that common, but as neurosurgeons, we come across, more or so often, depending on the focus of our practice. But it's important to be aware and to recognize, because often prompt and correct diagnosis is one of the most challenging part of the entire process. Thank you.
Thanks, Dr. Lanzino. That was fantastic. I don't see any immediate questions in the comments, so I might jump in with a question of my own, if that's okay, which is, you describe the history as patients, relatively elderly patients presenting with an indolent progressive spastic paraparesis and some sphincter involvement. But one of the most consistent symptoms that I've noticed in the patients that I've seen is that they've got the symptoms in the background, but they also get intermittent exacerbations. So they'll be walking down the street and then suddenly they feel like their legs are giving way. Do you have any insight into why they develop these intermittent exacerbations? Is it to do with variations in systemic blood pressure that are transmitted to the venous system through the shunt?
Yeah, we have definitely, we have seen and noticed that it looks like, I think in one of our publications, we associated that with the mid-thoracic location. I think it's probably the reason for that is multifactorial, but one of the important things to consider is that the Adamkiewicz, the flow through the Adamkiewicz, especially if arises at particular levels, can be influenced by the anatomical location and the surrounding musculature, which in turn is affected by the type of activity. And the other thing is that if there are activities where you increase the intra-abdominal pressure, that in turn might lead to further obstruction or slowing of venous return that can worsen symptoms. Another thing we have noticed is that these patients often they have surgery for symptoms that then in retrospect were probably related to the spinal vascular shunt. And if these patients, they have any type of surgery that is not related to fixing the fistula, and they are in the prone, especially in the prone position for prolonged period of times, and you don't worry about the maintaining an adequate perfusion to the spinal cord, they describe worsening of their symptoms after any type of surgery, especially if done in the prone position. So I think there is a lot that has to do with how the different activities or potential surgery or positions might affect the venous return that is already compromised.
Brilliant, thank you. Dr. Perek has a question. Would you like to go ahead?
Hi, Lanzino. Excellent lecture, as usual. Always you are very good in demonstrating this AV fistulas. I have heard you before also. I just had a query in my experience also, I found. Suppose you see a T2 hyperintense signal in a spinal cord in a thoracic region, and there is an AV fistula, you feel, and you treat either by embolization or by surgical, whatever way you want to. What is your experience in such a large number of cases is outcome, clinical outcome I'm talking about? What happens to the patient? Does the myelopathy reverses? They do come back to the normal, or they remain stable, stagnant, and don't deteriorate? What is your experience?
Yeah, my experience is that patients after surgery, about 15% of patients, they might experience some transient worsening after surgery. Most patients, if you treat the fistula, they experience some degree of improvement of their motor symptoms. That does not mean that they go to normal. So my experience is that at the beginning, the first few weeks, everybody's excited, the things are getting better. When they come back, the patients are not often that happy because these are often, as I said, elderly people that they want to be perfect, and they often don't go back to their normal morbid status. So that's one. But I would say to some degree, the motor symptoms almost always improve. Sensory symptoms, it's a hit and miss, it's about 50%. And if they have bowel and bladder compromise, that improves only in 1/3 of patients. The other two factors that are important to consider and to be aware, it's not uncommon for these patients, you treat the fistula, they do well, they are happy because they get somehow better. They come back after a year or two and now they say, I'm getting worse again. And you know that the fistula is treated. The problem in these patients is that now they're getting spasticity from the existing damage to the spinal cord, and they perceive the spasticity as increasing and progressive weakness. We run into that quite often. The other thing is also for the sensory symptoms, is somebody who has a decreased sensation, as they recover, and we know that one of the way the spinal cord recovers from sensory compromise is that they start getting a burning paresthesia. And so they come back and they might complain they feel they are worse, but it's true. It's not that they are truly worse, is that they're just experiencing paresthesia, as the spinal cord is the sensory component of the spinal cord and the nerves is recovering from the pre-existing. So it's a convoluted answer, but I know where you're coming from, because if you read the papers, they say, oh, there are miraculous recovery. But the truth is that in the majority of these patients, I tell them, my patients, I said, what I can do, if I find and treat the fistula, I can stop you from keep getting worse and worse and worse. Then if we're going to see improvement, well, that's great. And as I said, most of the motor symptoms, they tend to improve to some degree. But then as people start seeing improvement, they expect to go back to normal. And that's not always the case. Often it's not the case, I would say.
I 100% agree with you. In majority of patients, I don't have a large experience like yours, but whatever number of cases we have treated either by embolization or by surgery, the improvement is very little, maybe in initial phases, and then it stops further, especially when we have seen a hyperintense signal on a T2 evaluated image, which suggests either an ischemia or an infarct already there, as we all know. It's not a compressive, it's a vascular phenomena. So this is what is I wish to know. Okay, what the others think, and I rarely find that they become normal. No, the reflexes remains exact, and this problem of spasticity is really difficult to handle. Very difficult for a patient, and they keep on coming. They are not paralyzed, but because of the stiff legs, not able to make it headway. And another thing which we have observed is the posterior column sensations. They are worst, and they find difficulty in balancing because of the loss of posterior columns. So this is my experience. I'm just sharing with you a few patients, whatever we have done, and they don't do well. Only thing, yes, I agree, they stop deteriorating further. Definitely.
Yeah, and I think it's critical in the preoperative phase to really stress and make sure that the patient, and make sure there are family members around, because the patient, they like to hear, of course, naturally they want to get better, which is normal and fine.
Yeah.
But it's important to stress is that what we can do is to stop the progression of the disease. And we also know very well that if these are not treated, the progression is to eventually complete loss of motor, sensory, and sphincter function. So it's important to stress that, is that, and then they say, well, if we see any improvement, that's going to be great, and also to stress some of the pitfalls. Another thing that we see quite often is that since these are elderly people, then of course the aging process starts catching up with them, and they start feeling weaker because they have already less reserve to rely on, and as age catch up with them, they start feeling, weaker and weaker without any recurrence. It's just, but I agree with you. If you follow these patients, in few cases can be quite a frustrating process long term.
No, I tell my patients the same thing. If you get better, it is a bonus. The whole aim is to prevent further deterioration. Right. Thanks, Lanzino. Excellent lecture. Wonderful.
Thank you.
A lot of things to learn.
We've got 3 people with their hands up, so I'm going to move things along if that's okay. We'll go in order. It's Eduardo first, followed by Mohammed, and then Adi. So Eduardo, go ahead.
Thank you, Dr. Lanzino, and thank you also, Dr. Victor Hugo Perez, for your amazing presentation. I have just only one question or observation. Try to connect the 2 presentations. So we see from Dr. Hugo Perez's presentation that anterior and posterior radically medullary arteries originating in the most of cases from in a level that is located between T3 and T7, while the artery of Adamkiewicz tend to originate from T8 to L3. So there is also rich anastomosis as shown by the dissection of Dr. Hugo Perez in this passage from the mid-lower thoracic level to the higher and higher lumbar level. And this anastomosis, as shown in the dissection of Dr. Hugo Perez, tend to be located in the anterior lateral aspect of medullary. So what I would ask, as for your surgical and anatomical opinions, doctor, is there some possibilities that this site of anastomosis can be related with the high percentage of localization of dural spinal laterovenous fistula at this level?
Well, I would say that, definitely for the perimedullary, the perimedullary fistula arteriovenous shunts are not exclusive, but they are pretty much typically localized at the conus. There is no question that the conus medullaris arteriovenous shunts, they have a separate and a characteristic angioarchitecture that I think it is related to the anatomy, that so-called the basket of the conus. For the other types, there are so many different variations that the other types, especially the spinal dural ones, I think that more than a true anatomical the anatomical vascular anatomy, I suspect that because of the typical location, the relationship with the bony structures and how the dura and the microvessels in the dura interact with the different bony structures, potential role of trauma, relatively minor trauma, I think that might have more of importance. But for the conus medullaris and for some other types, there is no question that the beautiful anatomical connections and variations that Dr. Perez has shown are critical.
Thank you very much.
Excellent. We'll go on to Mohammed next.
Hi, Dr. Lanzino. Hi, everyone. Thanks very much for the fantastic lecture and thank you for these efforts. So I have one question actually. It's about the dividing of the spinal dural AVF regarding the spine region wise. So there are a few studies published about this before, like they divide the natural history and the treatment of these lesions regarding the region they compromise from the spinal cord. So do you think it's wise to do such classification for spinal dural AVFs, or we can just take them as a whole for, like there are no cervical spinal dural AVFs and phyam terminale, they have like their own presenting symptoms and their own characteristics. So do you think it's wise to divide them based on the spine region they compromise, or we can take them all as whole, like as a whole entity?
No, I think that it's important to consider the area of origin, because as I said, if the craniocervical junction fistulas are similar they share some similarities, I should say, with the spinal dura fistula. But in the remaining portion of the cervical cord, it's almost exceptional to find the true spinal vascular AV shunt. The ones we see more commonly, they are either epidural or they tend to be on the surface or parenchymal AVMs. So I would say that this true spinal dura fistula, it's pretty much localized to the thoracolumbar spine. Exceptionally, we see in the sacral spine, almost never in the cervical segments. And then the craniocervical junction, the C1, they are apart because they can present with hemorrhage, just the clinical presentation, while the true spinal dura fistula, this is another interesting thing, why we have these convoluted veins, but almost never these fistulas, they present with the hemorrhage, while the craniocervical junction, they, especially if they drain superiorly toward the brain, they can present with hemorrhage. If they drain inferiorly toward the spinal cord, more often than not, they present with myelopathy. So these lesions are fascinating because, again, we like classification so that our thinking it's simplified, but there are so many different subtleties that are related to location, angioarchitecture, symptomatology, and that at the end, as I said, the classification that makes more sense is the one that has been popularized by Dr. Spetzler in recent years, and that takes into account the anatomical location of the shunt in relation to the contents of the spine. And of course, then you consider also the characteristics of the different segments.
Thank you very much.
Excellent. And then the third person who had his hand up was Ardi. Dr. Lanzino, Ardi is my friend from Southampton. So Ardi, you go ahead.
Thank you, Dr. Lanzino and Dr. Perez, for the excellent lectures. Really useful and valuable. I had a question about the treatment of the spinal dural AV fistulas. You mentioned that I think surgery, you'd sort of favor surgery over the interventional radiology as a mainstay of treatment. Is there a subgroup of patients with a spinal dural AV fistula where you would consider interventional sort of radiological treatment over surgery? And what's your experience in terms of those patients who you treated with interventional radiology? What's the success rate and in terms of complete resolution? Thank you.
So yeah, there is definitely a subset of patients where we would consider, for example, first of all, of course, we make sure that there is no visible contribution to the spinal cord for not only the same segment, but also the segment above and below, because nowadays we use liquid embolic agents. And with the liquid embolic agents is that you don't have a lot of control where exactly the embolic agent is going to end up. And we say it easily connects the dots. If there is any potential for anastomosis, there is a risk there. So that's one criteria. The next criteria is that how reliable is the patient to come back. If I have a patient that is minimally symptomatic, and that patient is reliable and is going to come back for follow-up and is going to call us if perceives any degree of deterioration, then I think that patient can be, I would treat with the embolization, as opposed to the patient that has already significant compromise, lives far away. That patient, when he leaves my center, I would like to give him a certainty that the fistula is cured. So there is a subset. Our approach is that for any lesion, if you endovascular, the treatment is as safe and close to, in terms of effectiveness, to surgery, why not? The experience has been variable. We definitely have had some that I would consider cure, and some that eventually they came back. The problem with the embolization is that, as I said, that the key is to close the proximal portion of the draining vein. But especially if you use onyx, for example, the onyx coats the wall of the vein first. So angiographically, you might get the impression that you have closed the vein, while instead there is still a channel in the middle. And the other problem is that once you have closed the main feeder because you are using a liquid embolic agent, you never know if there are tiny little vessels that angiographically are not visible, but they might keep the fistula still alive. What we have learned is that if you do an MRI after a few weeks and the flow voids have resolved on MRI, that means cure of the fistula. If you still flow voids, then so the results have been mixed. And the problem that I have with embolization is that if the patient is not better, and we discussed that these patients often they improve some, but they rarely go back to a normal degree of function, then you never know, did I really treat the fistula, or is possible there might be still some. So it's a very difficult because but likely for this type of problem, as I said, that the localization and diagnosis is the most difficult part of the process. The treatment is pretty straightforward.
Thank you.
All right, excellent. John, are we running out of time, or do we have time for one more?
Go ahead. Yeah, one more.
I'm not sure whether we're going to manage to get to this, but we have one person who'd like to share a case. Do we have time to quickly share a case?
We just have a couple of minutes. I don't know how long it will take. If they
what we can do, Nick, though, we can keep that in mind. We are planning in the next, before Christmas, to do another session. It's going to, again, dedicated to spinal vascular malformation. So we would, I think that, but I also would ask the colleague to, if the case in question is to share opinions that might be needed for decision making, please share the case by email. We'll be happy to comment. But no, that's actually that was our original hope, is to have the ability to share cases and make it even more interactive.
So I've actually, Pawan, it was the person who wanted to share a case. Pawan, I've just sent you my email address. If you're willing to share that case with us by email, then we can somehow tie it into to the discussion next time.
Oh yeah, thank you.
That sounds great. That sounds great.
Very good. Excellent education, Dr. Lanzino and Nick. Quality stuff. And thanks everyone for coming, and we'll see you in a month.
Thank you, everybody.
And
Thank
Victor,
you.
And Victor's giving another presentation right now in Spanish neuroanatomy. We're making him work.
No rest for Dr. Perez. Thanks, everybody. It was excellent.
Thanks.
Thank you. See you in a month.
Thank you.
Thank you, guys.
Thank you.
Good to see you.
Okay, I gotta go. See you, Victor. I'll send you another link, okay?
Yeah, will be much better in Spanish.
Okay.